We actually have 7 minutes now to answer our audience questions, and I'll try to get through as many as we can, if not all of them. So I'm just going to go back and forth between the speakers. Jerry, the first one's for you. What medication, what do you recommend to decrease proteinuria if a patient has a high potassium on the ACE or ARB and does not have insurance coverage for the SGLT2? What's your best combination?
Yeah, that's hard because my first response was going to be an SGLT2 inhibitor because again, they don't usually raise the potassium and often it goes down. So that would be so. What I would do is if they've had a high potassium in the past, I would use first of all I'd start with an ARB with hydrochlorothiazide. Losartan with hydrochlorothiazide is potassium neutral. So if you do 50/12.5 or 100/25, you're not usually going to raise the potassium. And putting in the diuretic with it makes it much more potent. If you look at 100 milligrams of losartan, it's less potent than 50/12.5 is with the hydrochlorothiazide. So that's what I would do. I would use diuretics if at all possible. Now, it is the other thing. You can, of course, use potassium excreting drugs and, things that lower the potassium. But again, that's adding on other medicines. It's nice to be able to do it with one pill. So I think that's the answer.
Thank you. Gary, what do you advise patients with a calcium-based stone who's vitamin D deficient?
Yes, very important. We see this all the time, particularly since patients with stones are at much higher risk for low bone density. So we definitely want people to have adequate vitamin D. What I want to avoid is excessive vitamin D. There hasn't been any evidence from a decreased risk of fracture by putting people at very high doses. So we typically aim for a level of about 30. So if you have somebody on it, depending on they have malabsorption or not, they may have different doses. Typically, I would start somebody at 1,000 international units a day, recheck their 25D level, but definitely don't want it to be too high, but definitely don't want it to be too low either.
Gary, what about a lot of sunshine?
Yeah, Jerry, it's true, but there's 75% of the people in Phoenix are actually vitamin D deficient, and that's because they're either going outside with their skin covered or they're wearing sunscreen, which we want them to. Not to mention, as we get older, we don't generate as much. So I'm a big fan of that, but the dermatologists would hate us to be saying that. So there's lots of reasons not to do it. But people are still deficient even where they get way more sun than in Boston.
Jerry, in IgA, and this is broadly, in IgA nephropathy, do you trust the spot PCR or ACR, or do you use the 24-hour protein collection for risk evaluation?
I usually use the UP-UCR. Now, some people use the urine albumin UCR, but whichever you do, usually the U protein UCR comes out twice the level of the U albumin one. But I use that because it's just too hard to get the collections, and you're going to make more mistakes. Just people over collect. I can't tell you how many people we used to give them a collection jar, and everybody brought the jar just filled to the top. That's it. No matter how much you peed, you always just fill the bottle exactly to the top. So I think you'll know whether somebody has, 3 grams or 2 grams. Now, you might not know if they have a half a gram or 1 gram in terms of this when it gets down to lower levels, and then you just have to repeat it.
Gary,
I can maybe make a small comment. So I totally agree. I also use UACR. And again, just because of thing. Maybe one additional comment on dapagliflozin is now generic in the United States at cost plus drugs. It's about $5 a month. So it should be, if you don't have coverage, you should just go to cost plus drugs, and it's about $5 a month.
What about
I did not know that.
EMPA's not? Yeah, EMPA's not.
EMPA is not, but DAPA is. DAPA is now generic, and it's $5 a month. Yeah.
That's a huge change. Hey, Gary, are there any evidence-based treatments for recurrent struvite stones? What do you do to suppress infection?
Yeah, so really important. These stones are difficult to manage. So you definitely need the urologist involved there's two parts to it. So one is you want to get the stone completely removed because bacteria can hide in there. And if you just keep treating, eventually they're going to develop resistance. It's then our job as internists to try to prevent recurrent cystitis, because again, that's where the vast majority of the infections start and they ascend. So we should be checking urines very frequently, urine cultures when needed, and aggressively treating and making sure that the patients know that they need to get checked sooner. There is a drug for people with anatomic abnormalities, people with spinal cord injuries or other diversions that can inhibit the urease enzyme, but it's actually a very toxic medication, so I wouldn't recommend that. But just trying to stay on and do whatever you can to prevent recurrent urinary tract infections, particularly the cystitis. Again, that's where it's starting.
Thanks. Jerry, how long do you treat with budesonide or sparsentan for IgA?
Okay. So the sparsentan you can treat for an unlimited amount of time. And as I said, it's now the first drug that's FDA approved for focal sclerosis, which a lot of those people are going to need longer term therapy in terms of this. That for using budesonide, targeted release budesonide, the study is on 9 months worth of therapy. And then they stopped. And then that's when things started to, by 12 months, they were still okay. But by 15 months, things had gone back to the same place they were before. So people have tried different things. Some people have tried when they stop at 9 months, then they wait till it starts going back up and they do another cycle, as long as the person responded very well. The other thing is people have cut the dose. And instead of using 16 milligrams, they go down to 8 milligrams of the targeted release budesonide. And in terms of the lower dose, again, trying to keep away from the side effects that you get from steroids, because the side effects were very low with targeted release budesonide, but that's because the dose was kept for only 16 months. I'm sure if you did it for 2 years, you'd get more unless you use a lower dose. So this is still to be proven what the best therapy is at this point.
Do you have to stop the ACE or ARB when you start sparsentan?
Yes, because again, sparsentan essentially has an irbesartan-like molecule right in it. Mm-hmm. So you're already giving them one. Giving them two, it's just like if you give them an ARB, you're giving them just a bigger dose of the ARB if you use both. And if you used an ACE inhibitor with it, most of the studies have not shown ACE inhibitors and ARBs are better than using one drug. So, and again, the other thing is if you wanted more activity out of it, always adding the diuretic seems to make a difference, and that'll get rid of some potassium as well.
Yeah, that is, and if you're using newer agents like etanercept, do you keep the Jardiance or do you keep the SGLT2 on board, or are you worried about an increased risk of urinary tract infection?
Well, the good thing is now I'm not worried about cost. I was more worried about cost before that. No, I do keep them on board in terms of using the non-specific therapy because, again, all of these things do decrease proteinuria. And, now one question I haven't been asked yet is that, which way would I go? Would I go to an SGLT2 inhibitor first, or adding on to the ACE inhibitor and A or B, would I switch them to sparsentan or add atrasentan? In other words, use that dual first. And it depends on the patient. If they're an older patient where heart disease is a bigger thing, cardiovascular or diabetic, I would use the SGLT2 inhibitor. They have good evidence in terms of cardiovascular risk. If they're a younger patient, compliance is usually the biggest thing here. So switching from an ARB to sparsentan, a single medication, is probably, that's what I try to do again. And, because again, they're more likely to take one drug long-term than they are to take 2 drugs or 3 drugs.
Mm-hmm. Gary, are there any studies using Vaptans to increase urinary volume and reduce supersaturation in stone formers?
There have been some small ones that have tried, and again, it does increase urine volume, but there's risk to taking medications. I don't do that. I'm not saying people can't do that. Dr. Tangri mentioned about cost. I don't believe that there is a generic for that in the United States, and it's actually quite expensive. So there's other approaches that can be done. So I wouldn't recommend that.
Okay, and on that, do you have any specific recommendation for the type of fluid? Water alone, coffee, tea, juice? What's your preference? What do you recommend?
Okay, well, we've actually done a bunch of research on the individual types of beverages, so I'll keep it brief, but a few things. Water's safest, cheapest, and easiest. I think there's generic water in the US, Dr. Tangri, is that correct? Okay, so that's cheap, but a lot of people don't like it. So there can be ones with artificial, some flavoring, which would be absolutely fine. Okay, but I don't want anything with calories. The goal here is not to gain weight. We've previously shown that weight gain is associated with increased risk of stones. Coffee, tea are actually fine. Coffee does increase your calcium a little bit, but if you're focused on stone prevention, we've actually shown that both coffee and tea reduce the risk of stones. Juices like orange juice has citrate in it, raises urine citrate, so that's beneficial. But I don't recommend that because of the calories involved. Alcohol actually is also protective, but I don't know what's in your cup, Jerry. I assume that it's coffee that you're showing me.
Chardonnay.
Okay. But again, I don't prescribe alcohol to reduce the risk of stones, but I also tell people they don't have to avoid it. So many times in medicine, we're always saying, don't do this, don't do this. Occasional alcohol with respect to stones is actually fine.
Dr. Tangri, does the readiness screen for CKD detection work for non-diabetic patients?
Yeah, it tends to work for non because there's microvascular disease that is just picking up. The water also comes from Canada, but it's subject to tariffs, so it might be more expensive now. So hard to say. But yes, the screening works independent of diabetes. Yeah.
All right, Gary, back to you. If you have a patient who's on a thiazide diuretic and he has improved stone burden, given the no stone trial that showed increased adverse metabolic effects of the thiazide, how do you counsel your patients whether should they continue or discontinue the thiazide?
Yeah, I would say it's an individual cost benefit, like all things that we do in medicine. If their burden, the thiazide, I don't expect the burden to go down. I'd expect it not to increase, okay? But if they've been on it for a while and their serum potassium is fine, if it's a little bit low, we have lots of ways to fix that. It's the opposite problem that Jerry has, but we're able to get people's potassium up. If there's metabolic, like their glucose is altered, then again, there's other considerations that have to be taken. But if it's working for the prescribed reason and they're not having any side effects, then I usually encourage the patients to continue it. But again, if they've made major dietary changes, then we can't emphasize the importance of diet. That dietary modification may allow people to come off medication.
All right. Well, we are out of time, so we're going to move on to our next topic.
Thank you so much.
Thank you very much for sticking around.